Well, good evening, everyone. Thanks for joining us for this AUA webinar. So we're going to cover some of the emerging use of ctDNA as well as urine tumor DNA that's coming up in bladder cancer. So certainly, familiar with a lot of the growing evidence within muscle-invasive bladder cancer, but the purpose of this webinar is to take some of that evidence and really dive into how is it being used now in, urologic and the multidisciplinary care of patients? And so, I'm Adam Elnagar. I'm the Senior Medical Director for GU and GYN at Natera. And so I'll be moderating, and then we have two additional panelists here with us. I guess we'll start on the first one on the left there.
I'm Laura Bukavina. I'm a urologic oncologist here at Cleveland Clinic, and I'm also the translational research lead for GU Oncology, and I work with Dr. Shilpa Gupta.
Hi everyone, I'm Shilpa Gupta. I'm a geomedical oncologist and director for the geo program at the clinic. Really excited to be here.
Yeah, and we're excited that to have both of you on and from the same institution where you guys are working together already, so we can cover a lot of like what's that paradigm like, what's that interaction like as you guys jointly work on care for patients. And so again, it's going to be mainly working on what are the clinical roles for ctDNA, understanding some of the molecular testing, how it can be used, what it means and then really dive into some real world cases that you guys have pulled together to present to this webinar. And so, why molecular data within this place? Why is there a need? Is like one is the understaging. So, we know that a lot of muscle invasive bladder can be understaged when you're going in or managed as non-muscle invasive when it is muscle invasive. So how do we manage that? Certainly limitations when we talk about cystoscopy, cytology, and imaging in these non-muscle invasive patients or when they're unresponsive to therapy. And so I think this non-muscle invasive is an emerging space where we're starting to see use in ctDNA, and I think we'll hit on that a little bit. And then, of course, there's, the role of how do we identify patients that are most likely to benefit from systemic therapy, particularly like adjuvant therapy. And so just a quick platform overview. Dr. Gupta, if you want to talk about that.
Yeah, thanks, Adam. So we made a lot of progress over the last few years in biomarkers in bladder cancer, urothelial cancer in general, and there are several MRD modalities in urothelial cancer. One is, as we know, the circulating tumor DNA, which is shed in the plasma, and it reflects systemic micrometastatic disease or patients with overt systemic metastatic disease. Then we have the urine tumor DNA, which where the cells are shed in the urine, and that by name it suggests that it probably would be a better tool for localized disease, early detection, like non-muscle invasive disease probably. So together they can offer a complementary lens on recurrence risk, early detection, treatment response, staging, and monitoring. Next slide. So UroAMP is a urine tumor DNA MRD platform, and this is a non-invasive urine-based sequencing from urothelial cancer, and it has been shown to have high detection rates for local residual disease, even when the standard conventional tools like cystoscopy or imaging appear negative. And we know that a lot of times, like you said, patients are understaged, and we really need such early detection tools. And it has shown a strong performance in non-muscle invasive bladder cancer, as well as perioperative settings in MIBC for addressing local tumor biology. And the urine tumor DNA negativity or clearance correlates with pathologic complete responses after neoadjuvant therapy. And this is, we also saw in the Sunrise 4 at ESMO. And this was, we saw that at baseline, around 82% patients with visibly complete and 84% patients with visibly incomplete TURBT were urine tumor DNA positive. So I see a lot of promise with this platform moving forward. This is just early blush of the data. Next slide. And predicine care urine assay is another urine-based cell-free tumor DNA assay, which is used to detect genomic alterations associated with urothelial cancer. And it can also evaluate multiple clinically relevant mutations like the TERT promoter, TP53, FGFR3, which can be targeted with therapies. And it has shown utility in identifying residual disease as well as early recurrence in exploratory studies. And it's currently under FDA review as a potential companion diagnostic for immunotherapy trials in bladder cancer. It's also been investigated both in localized and metastatic urothelial cancer as an MRD tool. So together, it can provide an alternative approach for patients unable to undergo frequent cystoscopic evaluation. And I see, and Laura can comment on that, a lot of promise with this. There's a lot of logistics and coordination for repeat cystoscopies, TURBTs, not to mention the cost burden and the financial burden. So I think moving forward, these tools will make quality of life easier for patients and burden less on the providers. And Signatera has really shown promise in bladder cancer so far, cross stages, and it's a residual disease MRD assay. It's a personalized and tumor-informed approach using a single tumor sample where we use an archival tissue to identify unique signature of tumor mutations and then custom design MPCR assay for each patient targeting the top 16 clonal mutations found in tumor. And this is unique for every patient. And that's, I think, one of the pros of this assay. It uses the personalized assay to detect presence of circulating tumor DNA in patient's blood. Now, of course, for this, we need to have sufficient archival tissue.
Yeah. Well, thank you for that overview. And so, we're going to be touching a lot on how do we use these MRD assays within bladder cancer. And so kind of how did we get here? And so it's been an exciting journey. And so, probably one of the launching points for the evidence on how can we start integrating this into clinical practice for these patients was when we looked at a retrospective biobank out of our house university. And so in this was patients that had neoadjuvant chemotherapy, cystectomy, and then had time points collected during surveillance. And so these are the overall survival KM plots for the various time points. So when we looked at patients that were, after TUR, ctDNA negative versus positive, you see those negative patients that then went on to have therapy had an excellent survival. And then we start to capture in that predictive piece of the test to say, okay, well, you had that starting point. If you cleared your ctDNA or stayed negative, what did that mean? And so that's the next KM curve where we say if you're negative or positive going into cystectomy. And then the last one there is on the right. And so now we're starting to get into the surveillance piece. And so if patients are when they're undergoing serial monitoring, if they remain negative, none of the patients were going on to have events. The patients that were having the recurrent events were the ones that became positive during monitoring. And so, kind of proof of principle, we can detect it. It's prognostic at these time points. Maybe there's some signs of predictive value. Well, how does this work when we start talking about interventions being done? And so that's where IMvigor10 comes in. So, that was a randomized trial looking at atezo versus observation in muscle invasive bladder cancer. So after surgery, patients were randomized 1-to-1. And so, not shown here is the actual primary endpoint of the study, which was an 800 patient international phase 3 trial that was negative for lack of benefit with the addition of atezo. And then even when they looked at it by a biomarker eligible population and said PD-L1 and TMB, there still was no difference in that survival. Then we looked back at a pre-planned analysis to look at ctDNA, and that's what's shown here, is capturing if you were ctDNA negative, treatment, no treatment, those patients had a good outcome, and so you weren't improving it by the addition of the drug. Whereas in the bottom curves, the more solid lines, those are the patients that are CTA positive. And so when we added therapy to them, it did improve their survival. And so this was pretty exciting to see that maybe it can start to be a stratification factor to this. And then, of course, coinciding it was similar data in colorectal cancer and in breast, and emerging data in other solid tumors. So then we move into IMvigor 11. So the question being, okay, so we showed that retrospectively it's very exciting, but we don't know if positive patients, yeah, they do bad, but can you really improve their outcome? Can we really make a difference here? And so that's where Vigor 11 is the confirmatory to trial to say, okay, if you are CTA positive, those are the patients we're going to intervene on and see if we can really improve their outcome. And this is what the most recent data was. Yes, intervening on positive patients can improve disease-free survival and their overall survival. And so, now we have this. Of course, the more data you generate, the more questions it generates. So how do we start putting it in other places? And then there's other analytes coming into the field as well. And I think you've already alluded to it just earlier about Sunrise.
Yeah, so we saw at ESMO for the first time in a clinical trial, Sunrise 4, that urine tumor DNA negativity and clearance enriched for PCR in this MIBC patients. And at week 12, we saw that the urine tumor DNA is strongly associated with PCR, and the baseline positivity was over 80%, which is pretty good. So I think, this is another tool. Now we've learned a lot with the ctDNA, and moving forward, we'll use urine tumor DNA. And I think together it would be really very rich assessment for our patients using both the tools.
Yeah. And so that's some of the key background we wanted to dive into, and then spend the remainder of the time really focusing on the practical applications and how it's being used in clinic today. And so we're going to hit some real world patients that you guys have selected out to kind of be some cases for us to walk through.
Thank you, Adam, and thank you for having me join today. I think this is an incredible opportunity for many of us within urology to be able to use this test and learn how we can use it in both the very high risk patients of the non-muscle invasive patients, but also work with our medical oncology colleagues to sort of start testing in the early setting, post TURBT in the muscle invasive setting. So I think, we went over a lot of data. We went over a lot of the urine and the ctDNA plasma data. I think the best practice for many of us is to understand how do we actually use this test within the clinical setting to actually make a difference, or at least I think we are making a difference by using this test. And I want to also say that this webinar is made for us. It's not, we're not we're not paid by Natera. I don't know if that makes a difference, but this is really meant to show how this test can help our patients within the clinical setting. So we'll start. This is a typical patient many of us see in the outpatient setting. This patient is a 66-year-old male. Some of the dates have been changed to protect patient privacy, but this is a patient who's failed BCG twice. He was diagnosed with non-muscle invasive bladder cancer a couple years prior. And, he underwent standard of care. He underwent CT imaging showing no upper tract lesions, failed BCG, had restaging imaging, again, failed again with T1 high grade at this time, underwent second induction BCG, and unfortunately failed shortly after within 5 months. So a very early recurrence post-second induction where he was found to have a TI high-grade tumor. So this is a patient that at this point, I see this patient after their diagnosis of TA high-grade after their second BCG failure. Next slide. The patient recently underwent a CT imaging at the time of their TA high-grade diagnosis, and the CT at that time showed potential mass versus scar, nothing really impressive. So you see them, you order ctDNA based on their high-risk invasive status, and the ctDNA comes back a couple weeks later as being positive. That's an alarming signal to have for a patient with non-muscle invasive disease, as it can really signify a much more aggressive tumor, whether it's locally invasive or potentially node positive or even metastatic disease. And even though patient had recent imaging in July, With the ctDNA positivity, we elected to repeat all restaging imaging, including MRI, CT chest, and CT abdomen. And you can see even within the short 2 months duration, patient's tumor went from TA high grade to now potentially local, T4 locally advanced N1 disease based on his MRI. So now he went from non-muscle invasive BCG unresponsive, ctDNA positive to now locally advanced pretty quickly. The question is, would this have changed if you just repeated imaging? I mean, I think the better question is, would you even repeat imaging in this patient who had imaging just shortly before they saw you? And I think many of us potentially might not have not. The patient eventually underwent EVP therapy because it was locally unresectable disease, had a great response. In fact, he went ctDNA negative after a couple of months of EVP therapy and did undergo surgical consolidation with PT2 disease at the time of his cystectomy and remains ctDNA negative. So this is an example of how we transitioned from non-muscle to locally advanced to systemic treatment and getting a patient a favorable outcome with the test of a ctDNA. Next.
Mhm. So
And we'll
if
move to, yeah, go ahead, Adam.
yeah, so this, when they come to see you and they're the TA high grade and then they come back ctDNA positive, and that's driving like, let's do a more aggressive workup for
Yeah.
disease. So if they had been negative, having received that kind of second induction, would you have been a little more comfortable with like pursuing a more conservative management or?
So if the patient had ctDNA negativity, we often restage them ourselves. So even if they had an outside provider diagnose them with TA disease, I would have still restaged them with my own TURBT. But would I have known that he's node positive? Probably not, based from my just cystoscopy. I would have known that he had at least muscle invasive disease. And that did change our management, right? He went from unresectable disease to getting EVP instead of me diagnosing him with just muscle invasive disease. So there was definitely an escalation of imaging and escalation of care because of that test.
Hmm.
So I want to talk a little bit about the role of ctDNA in the BCG naive and the BCG unresponsive space. We're getting a lot of trials within the BCG unresponsive space, and now we're moving into BCG naive space and the high risk and the very high risk cohort of patients, because I think there's now a clear understanding that what we thought initially as potentially not a life limiting disease, we now understand that a very high risk non-muscle invasive disease is potentially very easily metastasizable and is life limiting long term. We also are starting to understand what actually happens with many of these patients when they're getting subsequent salvage therapies. But even 5 years ago, we really did not have many options aside from cystectomy, which was done early on. However, now we have many patients that are getting at least 1 to 2 salvage intravesical treatments. So the time from the initial diagnosis of BCG unresponsive disease to, we're seeing patients 2, 3 years down the line, what is actually happening? We may be clearing the bladder, but are we giving time for potential disease spread? And many of the clinical trials in the BCG unresponsive space have very short follow-up, right? In terms of 3, 6, 12 months. The longest study we have is 5 years, and a lot of those patients ended up having cystectomy or fell out or censored out. So we have very limited understanding in terms of bladder preservation and salvage therapies 5 or 6 years down the line. And this was the first study that we saw published. This was an abstract at 2025 ASCO looking at ctDNA, plasma ctDNA in the non-muscle invasive space. And what they found is that 20% of these very high-risk patients, they kind of put all of them together, BCG unresponsive and BCG naive, did in fact have ctDNA positivity. And this was associated with metastatic disease at the time of their cystectomy and obviously worse outcomes for these patients. Next slide. And this was very, very close to heart because we have been working on measuring this ctDNA as well in our patients who are both high risk, very high risk BCG naive, and BCG unresponsive patients, and we found very similar findings. We found 24% of our patients were ctDNA positive. And ultimately, majority of the first diagnosis patients, so if you just became diagnosed with non-muscle invasive bladder cancer, the chances are you're probably ctDNA negative. As long as you're staged appropriately and you get a TURBT and a restaging TURBT and appropriate imaging, chances are you're probably ctDNA negative. But as we continue to get treatments, whether it's gemcitabine docetaxel or other treatments that are FDA approved, you're starting to see more and more and more and more of these patients become ctDNA positive. We may be clearing the bladder, but we're giving time for the disease to potentially spread. And the most common way it spreads is to your nodes. We see very often 9 times out of 10, it's a status of an early nodal disease. And our fellow here, Dr. Betty Wang, did the initial analysis. We're currently up to 55 patients. We're able to track this longitudinally for over 2 years. And we see this continuously sort of reinforce what we know is that we are potentially giving time for disease to spread. Next. So this is some of the patients that we talked about that are ctDNA positive. When they do, whether they fail intravesically or whether we have imaging finding concerning for metastatic disease, when they undergo cystectomy, you can see majority of these patients have locally aggressive disease, whether it's T1N2 or T3N1 or N2 disease. So, and the number, what I also find interesting, Adam, is the ctDNA level of those patients is very, very low. So I know there's not a lot of studies looking at correlation of ctDNA, like bony mets, lung mets, and nodal to actual value. But what we find is that it's slowly creeping up. We're not getting values of 200 and 300. We're getting like 0.02, 0.06, 0.05. And these numbers are very low, but they continuously climb up. Next.
Okay. So you're seeing them very low because hopefully
Yes.
we're dealing with, initially at least, micrometastatic disease.
Exactly.
It's somewhere it's in the nodes, but it's so small.
It's undetectable, but yeah, so because the numbers are so small and it's micrometastatic, as you mentioned, Adam, we cannot see this in imaging. In fact, majority of these patients underwent imaging and we cannot see anything on imaging, including PET scans and MRI.
And are you seeing any of these patients that are kind of this low-level positive, receiving intravesical therapy? Are you seeing clearances happen in those patients?
So far, out of 55 patients, I have not seen a single clearance.
So
Well, I have
really,
only seen clearance when we take out the bladder and the nose.
okay. So typically it's kind of cluing you in there might be something outside and be a little more aggressive in the workup. Okay.
It would
Correct.
be good to also have, in such cases, I would think, Laura, the urine tumor DNA, right? Whether
Correct.
that's clearing with your therapy, but there's still risk of micrometastatic disease, which we won't see
Yeah,
clearances.
absolutely, Shilpa. And we all know cytology is not a great test. So I think urine tDNA in conjunction with this, it would be something great because then we can see if it's localized versus sort of systemic disease, right? With limited sensitivity, but at least better than just cytology. Next slide. I think this is a cleaner sort of representation of what we're seeing. And this is done by one of our research fellows, Dr. Kenny Dogdu, looking again, this is the BCG naive and the BCG unresponsive cohort. So again, these are very, very high risk patients. These are not your low grade tumors. These are high risk, very high risk individuals. And what we find is that patients who are ctDNA positive, they get restaged immediately with extensive imaging and cystoscopy and biopsies and blue light. And some of them do get upstaged with imaging. So what ctDNA does, it actually kind of makes us get more involved, sort of surveil upstaging imaging. A lot of times we don't get an MRI of the bladder, but we do in this case when their ctDNA gets positive. However, we still find that many of these are still considered to be, T1, and we don't see anything on radiographic concerning radiographically, but you see majority of these patients are N1 or N2, or at least locally or locally advanced in terms of muscle invasive disease, or even higher. What we also find are the patients who are ctDNA negative, but however have failed therapy and don't want any more salvage therapies, right? Whether it's their quality of life considerations or cost, or sometimes people just are done with it. We also find that those patients do really well. So those patients who are ctDNA negative and they failed multiple intravesical treatments, those patients, majority of them have really low-grade disease, low-stage disease at the time of cystectomy. So that's reassuring for us to also potentially use sort of on the other side, right? If you do want to continue intravesical therapies, salvage therapies, and you're ctDNA negative, you probably can. We can try and potentially other therapies to try to save your bladder.
Uh, so yeah, just looking at this, the positive ones, you see all the N1s and 2, and then you see all the N0s in the negative group.
Yeah.
And so as you're giving them these are all patients that are ending up with cystectomy, but as you're giving them intravesical and they're unresponsive to the therapy, it's leading, I think, to your point, is it providing some support that, okay, it's worth trying some more because there's not something else happening outside.
Correct.
I'm not giving more time for something else.
Correct. And sort of the last point on this is that ctDNA without the urine is a great marker for pathological upstaging. Even if we don't clinically upstage them based on imaging, it outperforms any kind of radiographic or even our cystoscopy and biopsies. It performs better at the pathological upstaging at the time of cystectomy, right? So 7 out of 9 patients who underwent a cystectomy who were ctDNA positive were upstaged at the time of cystectomy. And it's not 100% accurate test. I think nothing in our lifetime currently is 100%, whether it's utDNA or ctDNA or any other test that we use. But I think it's a great predictive marker. And clinically, it's very important to have when you're having these discussions with patients. You turned positive. We have this data to show that it's a poor prognostic sign, right? We perhaps should be not considering any more intravesical therapies. We should be considering better restaging imaging, potentially cystoscopies with biopsies, and see where you are, where you stand. And if all of that is negative, that puts us in sort of this predicament. We don't find anything, but we know you're ctDNA positive. And so that to me is a gray zone, honestly. We talked about this at Tumor Board all the time, and I think Shilpa's even past week, where we have these patients where we honestly don't find anything and they're positive. And I know it's just a matter of time before they turn positive, but there's really not anything I can do. The only thing I can do at this time is just strict surveillance and potentially restaging earlier than I typically would.
And I think in this setting, Laura, there could be also some false positives, right? And your time to detecting metastatic disease may be longer, or I was wondering if you've had any such cases of false positivity, or
We
they're always
haven't
a harbinger of metastatic disease.
we haven't yet, Shilpa. I wonder, this kind of going back to Adam's point, like, do they ever turn negative? And I haven't seen any that once they turn positive, I haven't seen any turn negative by themselves, which to me would be more of a sign of a false positivity if we didn't do anything, but I have not seen any yet.
Okay. So I think that's maybe the question in the chat there, is that if you were ctDNA positive and you went in and did a TUR, you're not seeing them, their ctDNA then have a clearance.
No,
Okay.
no.
I think those patients are the ones you'll do scans a little more frequently because that's the only thing you can do.
Correct. Next slide. So this is just another example of pathway of how we use it in the non-muscle invasive space. So this is a very similar patient. However, this one had T1 high-grade bladder cancer. had BCG failure and gemdosi following, pretty quick sort of failure, and then following gemdosi thereafter. Patient became positive just a couple months after starting gemdosi, so just about 3 months after gemdosi. So this was all very quick, which is also a very alarming signal to me. I think when patients fail therapy very quickly, and they turn positive very quickly, that's a very high-risk patient. Patient had on a restaging, so this is I'm talking about restaging very quickly as soon as they turned positive, even though the patient was really not due for any sort of surveillance imaging for probably 6 months. He was restaged when the MRI and CT and a TURBT. Surprisingly, the TURBT was T1. And he's failed 2 treatments before. We talked about his ctDNA status. We talked about his MRI, and the patient was elected to undergo a cystectomy. Surprisingly, even though his pathology, right, and we have world-class GU trained pathologists here who still, and we went back and re-reviewed the pathology, and the MRI was negative for T2 invasion. His final path, even though his surgery was within the month of all of this, was T2. And the only thing that really showed that muscle invasive disease was his ctDNA. And he was a patient that after his cystectomy had adjuvant therapy, and he became negative pretty quickly and has stayed negative for a very long time. So this, a perfect example of how this potentially, could we say saved a patient life, saved him from metastases, made a clinical difference, whichever way you want to phrase it, but it did.
And it's interesting that even MRI didn't show you because
Yeah,
it's usually a good proof.
exactly. And we actually went back and represented this case at tumor board because we said, okay, is our MRI protocol maybe not ideal? What is going on? T2 within a month of an MRI. And we reviewed it with multiple radiologists, and there was no evidence of muscle invasion per their criteria. So.
Wow.
All right, and then last, before I let Dr. Gupta take over, talk about muscle invasive disease. So we routinely, urologists being sort of the first stop many times with bladder cancer, we have started ordering ctDNA earlier on. So as soon as the patient undergoes a TURBT, we order their ctDNA. In this case, this was a 68-year-old female who was diagnosed with a clinical T2 micropapillary disease. She underwent a cystectomy. She had a very high-risk micropapillary disease, so she did not get neoadjuvant therapy. However, she underwent cystectomy. Shortly after, you see her undergoing cystectomy here, and about 5 or 6 months after her cystectomy, she did turn positive. Her CT abdomen and pelvis was, so she was mid-cycle, so she was supposed to get it at 3 months. She just got a scan and turned positive. She got repeated scans about 8 weeks after her original scans. And her CT abdomen pelvis showed that she had an enlarging lymph node right above our lymph node dissection template. So right above it, it was PET CT positive. She was discussed at tumor board. She went radiation in addition to pembrolizumab. And, her ctDNA declined almost immediately after that. And she's been ctDNA negative for almost a year at this point. With just that adjuvant treatment. So this is, having that longitudinal collection starting right up before cystectomy, after cystectomy, whether they get adjuvant therapy or not. I think it sort of allows us to get to de-escalate or escalate surveillance imaging in patients who need it, right? That's sort of how we use it. We don't treat based on the ctDNA number alone. But what we do is we get imaging and make our decisions based on what we find from there.
Mm-hmm. But so not making a decision to like intervene necessarily, but it's identifying that disease earlier, prompting like a further workup or different imaging.
Correct.
And that is good intervention, right? Like Laura said, sometimes we have patients on 4 to 6 month scan protocols, and that's the time when you want to move it up. And that I think you're saving a lot of time.
Yep, exactly.
And you mentioned, getting the testing earlier on, like right after the TUR, like pre-cystectomy. Let's take out the micropapillary and just traditional urothelial. Like, how is a negative result or a positive result after TUR help like going into
Yeah.
decision making?
I have to tell you, I should have included some of that data, but we know that the patients who are truly ctDNA negative before any neoadjuvant chemotherapy, those are 90, I can tell you right off, 93% of those patients stay ctDNA negative. So out of our 80, I think more than 80% 80 patients that we have here, we have longitudinal data over 2 years. If they are ctDNA negative from the very start after their TURBT, that's the best sort of prognosticator for their recurrence. Now, if they were negative after neoadjuvant chemotherapy, that's sort of a mid-tier group. I think they have a much higher risk of recurrence. I do have this suspicion that systemic therapy sometimes reduces the ctDNA circulating tumor DNA. However, there's still sort of these micrometastases. It might be sort of in the senescence, tumor senescence or whatever you want to call it. So we do find that sometimes those patients who are positive turn negative have the ability to turn positive again sometime in follow-up. But the truly negative ones, those have the best outcome in terms of recurrence.
I think we see that in other tumor types too when we look at like serial testing on treatment is after some like local intervention, so a TUR, excision of mass or something like that, and you're negative, yes, those starting negatives go through treatment, stay negative are far and away. And then what's interesting is we've looked at just kind of what you're saying is those that clear right away are like an exceptional group. Those that take to cycle 3, 4 to clear are a little bit different. And then when you're still positive further than that, they're just not going on to clear and different.
Yeah. And one other thing, Adam, is when we do cystectomy and lymph node dissection for patients, the ones who are negative to begin with, 100% of those patients never have lymph node involvement. Patients who are positive but turn negative, we still find patients who are node positive at the time of cystectomy, even though they're technically ctDNA negative before their actual cystectomy.
Okay.
So that's sort of
And I
that
think
common.
in the IMvigor01, Adam, there were a subset of patients who in the surveillance phase had ctDNA negative, but on the scans they had lymph node positive disease. So I think that's one of the scenarios where the shedding is not very high, but they can have lymph node mets, but there were no visceral metastases. But I think mostly they were lymph node metastases and maybe
Yeah.
lung metastases. But yeah, that's something, nothing is 100%. So
Yeah.
that's one of
And
the pitfalls.
when we look at what CTA is doing when patients are on therapy, is it's not necessarily the clearance is due to you have no disease, because you need there to be disease and you need that disease to be active. And so if the therapy is effective, and I think this goes to your point, Laura, is you were positive, suggesting there was maybe more going on, but you've responded to therapy. And so it's shrinking the tumor, it's suppressing the shedding or things like that, which is why you're clearing on therapy. But to your point, that might be why they kind of fall
Yeah.
in this intermediate group.
And I think the easiest way to think about it in clinical terms, in terms of what can we do with this data, is assigning risks in terms of surveillance for patients, right? If you're
Mhm.
ctDNA positive, but you quickly turn negative, perhaps your surveillance should be, 4 to 6 months in terms of imaging, as long as you stay negative. If you're negative and you stay negative, do we have to do every 3 months surveillance? Probably not, right? So that's where I think the easiest way where we can reduce that imaging burden for patients, and that would be the easiest way for us to do so.
Yeah.
Next slide. Oh, so I think this is my last slide, but this is sort of our approach, how we use, there's so many tests coming out right now for non-muscle invasive space and muscle invasive space in terms of risk stratifying patients and potentially targeting genomic alterations. So this is our approach currently at the clinic. And Dr. Gupta sees a lot of this, when we share patients, but This is an example of one of my patients who was actually TA high grade. So by definition, depending on what definition you look at, if he's either intermediate by AUA or high risk by EAU, TA high grade, I'm sorry, use 4 centimeters, so a high risk patient by either criteria. But what you actually look is this patient got a ctDNA test right off the bat, which was negative. He got a Vesta AI predictor test, which showed him to be incredibly high risk. So more so than you would expect, right? So 88th percentile for recurrence and 82nd percentile for progression. So this helps us to have that discussion. I am more worried about this patient. I'm going to be getting ctDNA as he's getting intravesical therapy because I'm worried about his progression score. We also know we also get staging with an MRI if this patient turns positive or if he fails intravesical therapy. First test I'm getting is an MRI. And then we also start looking at potential genetic alterations. So if he unfortunately metastasizes, which is something for many of us urologists that deal with non-muscle invasive space, that's an opportunity to cure a patient. But if he does metastasize, we have ERBB2 mutations here, we have HER2 staining, and this patient already has sort of everything set up for them to succeed. And I think ctDNA is a huge component of that.
All right, Shilpa, you're on the spot now.
Yeah, so thanks, Laura, for walking us through those cases, some of them, early on that you're detecting more aggressive disease. So I think as time goes and we have prospective trials that would help us in future. So this is a patient, actually, Laura, I shared this patient with you. We reviewed her at Tumor Board. So she came to us, over 3 years ago with metastatic urothelial cancer with literally like cannonball metastases in her lungs. We treated her with Gemcis. She went on my trial, the main cap trial. She was on the standard of care arm of Gemcis followed by Velumab. Her lung lesions actually resolved. And then in September of last year, she had an upper tract recurrence. And per protocol, she had to come off trial. And we treated her with enfortumab vedotin for about 7-8 months. She didn't tolerate it that well, but she did have a radiographic response. She was having these recurrent UTIs. So Laura took her for nephroureterectomy. And she had PT2 and zero disease, although there was this big lymph node we were seeing on the scans, but it was not metastatic. And then right now she only has an MIBC and has received intravesical gemdosi. So this was her trends for ctDNA. And, the arrow there points when I treated her with EV, when we had that recurrence. And as you can see on the scan, and now since then, just with few doses of EV, she's been off therapy now pretty much over 6 months and really thriving. And her ctDNA has been negative. There's no evidence of disease distantly. So we are monitoring her closely. We did see a very small lymph node, but again, ctDNA is negative. So we're pushing the scan up to follow that more closely. Next.
I just
So this
want
is,
to make a comment for this. So she's had follow-up with Dr. Gupta since 2022, but the problem is that, her original disease, and this is, I think, a limitation, is her original disease was a biopsy from, I believe, a lung lesion or a lymph node. So there was very little tissue. So we don't have ctDNA for her, like through her systemic therapy and her metastatic disease. We
no,
only
I
have
think she had tissue, but we weren't using this assay back then, 4 years ago.
Right, but even within 2024, the first time we really got tissue was for her bladder because she had concurrent bladder cancer and she had upper tract. So she was able to undergo ctDNA testing off of her bladder tumor that we resected off of T1. That's how we're able to start monitoring her
Yeah.
ctDNA.
And
But
that I think is with this assay, you do need a good chunk of tumor,
correct. Yeah,
which
so
is why
that's
I think tumor uninformed assays would be of help too. So like we reviewed before. So yeah, this is good, reassuring to see this patient who's had a long journey now with metastatic disease, and now hopefully she can remain off treatment and we'll monitor her closely. Next slide. And this is actually another interesting patient I had. He was also a clinical trial patient. He was on the Morpheus trial where for MIBC. He received perioperative atezolizumab, neoadjuvant, and then adjuvantly. He underwent cystectomy and he had PT2, I believe, at surgery. So didn't have downstaging, but so underwent atezo for a year. Remained no evidence of disease on scans. And now, granted, there's only one ctDNA test here, but I can tell you why that was important for this patient. And his ctDNA, we thought, okay, we'll start checking it now, and the scans in July were negative, early July, and then the ctDNA done, which was detectable. So I actually moved his scans. Had I not had this test, I would not have done his scans until October or November, because he's, not even within 2 years of, he's past that 2-year mark. And so we moved the scans up and we found that he had a new peritoneal met right there, a solitary met. And he's currently on enfortumab vedotin monotherapy because he's had immunotherapy before. So we'll obviously now have the serial ctDNA testing to see. But I thought this was an interesting case where actually the patient sent me message that my test is positive, and then we moved up the scan. So this is one instance. And just today I saw another patient. We didn't have time to include her on this, but literally she was a metastatic urothelial cancer patient, had been on chemo and immunotherapy, and then had disease recurrence in lymph nodes. So we treated her with EV, and she had a response. It's just lymph node metastases, so didn't tolerate it well, but had a response. So we kept her off treatment. So she last received it in 2021, was off treatment for 2 years, and in 2023 again had nodal recurrence. So I biopsied and then was following on ctDNA. I treated her with EV again at reduced dose. Lymph nodes went away. So she was off treatment again. And since last year, I've been following this lymph node, which is pretty small, and like about 1.5 centimeter in short axis, and kept her off treatment. And her ctDNA was negative. And just today, we saw that her ctDNA shot up, and the lymph node, I wouldn't say it was a dramatic increase in the size. If I didn't have the ctDNA value, I would still be okay monitoring it. But because it shot up, now I'm going to re-challenge her with EV. So I think these are some instances where we are helping patients stay off therapy and use it when needed. And hopefully, if we do another webinar, I'll have more information on her course. But yeah, these are the real world cases where we are collaborating with the platforms.
Perfect. You guys are great. We got right through all those cases with 10 minutes to go for Q&A, which I think was the plan. So we're right on track. One question that's showing up in the chat is we hit on kind of that ctDNA positivity in the setting of kind of that negative intravesical workup. I think the question is about a positive urine test when kind of cytology, cystoimaging is negative. Any concerns there or experience there? So instead of ctDNA, it's a urine test that's positive while you're doing your workup.
Right. If the urine cytology is negative, but the test is positive, is that the question? Sorry.
Yeah.
Okay. Well, it depends on the urine test that you're using, right? There's so many of them out there, and there's always a concern for potential the field effect. We saw that even in the Sunrise data provided, right? I mean, they had utDNA negativity, positivity when there was a clinical CR, right? So that's about 20%. So I would be concerned. But again, you have to show some sort of pathological disease before you make a decision on it. So you have to have either pathology or a biopsy to show that there's disease recurrence. I think going off just based on the urine test is difficult these days because nothing
Yeah.
is close.
I think you do need, we can't let go of the pathology aspect of things for sure.
It would potentially push you to do more strict surveillance or potentially push the patients for doing blue light cystoscopy or random biopsies, prostatic biopsies, upper tract surveillance, like all these things that maybe you wouldn't do otherwise. But it would push me to do that more than treat patients based on a positive test.
So I see there's another question, and I can take a pitch at this, the one on the InVigor011. So Scott is asking us if how to apply the InVigor011 in the setting of neoadjuvant and adjuvant regimen. And if we were to design an adjuvant trial, should the decision for adjuvant be based on single time point ctDNA or longitudinal? So I think the first question, InVigor011 is the first trial to show the utility of ctDNA in a prospective randomized phase 3 setting, where we can potentially really say for sure that these are the patients who will benefit from adjuvant immunotherapy. Now, atezolizumab is currently not used in the adjuvant setting, so I believe we'll see if that becomes an option. But I would say that this should prompt us to use that in, extrapolate that to other trials. Like, it's really hard to do a new trial for every regimen out there. So, we have a modern trial going on right now through Alliance where we're going to look at CT, or Medgalski's trial where they're looking at use of ctDNA to intensify the adjuvant regimen. But to me, I think I will start looking at my patients who get some kind of neoadjuvant therapy and in the adjuvant setting, whether or not they need full course of EV-pembro, for example, or whatever therapy there may be. I think I'll have to use some complement decision making using ctDNA. And in the adjuvant trial, the question definitely, I think we need serial testing. One value cannot prompt us to do. And that's why in the InVigor011, there was that really 12-month grace period, right? You could turn positive at any time, and then you could get treated. So I think that's the concept we will be dealing with as to holding off on systemic therapy unless absolutely needed.
Yeah.
And
And
to
so,
sorry, Adam, go ahead.
no, go ahead. No, you're feeding off.
And to Shilpa's point, I think not only longitudinal, but also, going back to the pre-cystectomy to be able to really risk stratify patients and not just post-cystectomy ctDNA, because we're missing a huge chunk of their risk stratification by just obtaining the post-cystectomy ctDNA.
Yeah.
And so I think we can tie two questions together is when, one of Scott's questions about adjuvant decision making, is it a single time point or, the extended adjuvant window piece that InVigor used, which I think you started to comment on. And then there's another question about how often do you do ctDNA? So I think we hit on it a lot in the perioperative. So maybe focus more on the surveillance adjuvant setting in terms of the cadence.
Yeah, I think the cadence for me, it's usually between 6 to 12 weeks, alternating with the CT scan. So you're doing it, you have some lead time before you decide to pull the trigger on the scans.
When you say alternating, meaning you get it in between and at the
yes,
time of
in
scans,
between.
or okay.
In between. So if we are doing every 3 months, then we try to do it between like 6 weeks between scans.
Okay.
And if we are doing every 6 weeks, then that's
okay. So in between the scans and at the time of the scan. So that's kind of the cadence we're sticking with. Okay. Yeah, that makes sense there. And so, Laura, you had pointed out a macro papillary case, and I think that's the next study question there about variant histology and what you're seeing there.
They perform equally well. I mean, variant histology, we all know it tends to be more aggressive. So these patients, a lot of them have nodal disease or locally advanced disease already. So they tend to be more positive, I think, in our cohort. And if you look at all of our muscle invasive patients, we actually have a very high variant proportion. 44% of our patients have some sort of variant. So we have incredible data on these variants as well, showing much higher than predicted positivity.
And then since I have the two of you that cover kind of both aspects of the approach, is kind of what do you see as like best practices for when you're communicating between like the team and the management of whether it's high risk NMIBC or the perioperative muscle invasive, like, how do you see coordinating teams and communicating around it?
Well, I communicate, so I get all of my results on email. So I typically know who's the medical oncologist who's with me. And then if their ctDNA is positive or it turns positive, I shoot an email right away and say, hey, they turned positive.
And now, I think the important thing is it's not integrated in our EMR, right? So half the times the reports don't get scanned. So
Yeah.
my nurse and I actually look at the portal during my clinic nowadays. So if somebody is telling me that, the team didn't come to draw our blood, so we're checking. So that's, I think, working out better, but it would be really helpful to eventually have it in EMR. But I
Mhm.
think the portal is pretty convenient.
Yeah, we are integrating more and more. So Epic, Flatiron, it is an option there.
There was a question about upper tract disease. I think that's an important question. So, many of us urologists understand the limits of ctDNA testing, tumor, there's tumor agnostic assays for upper tract disease, but if you want tumor informed, it's unlikely that you will have preoperative ctDNA tumor informed on upper tract disease because we just cannot biopsy enough. So at this time, what we actually do is we actually send in their blood work. We send in their ctDNA like a couple weeks before the surgery. Then we do the nephroureterectomy. And then we send another ctDNA couple, 6 weeks after the surgery, and they're able to run both pre and post-operative tests based off the pathology from your nephroureterectomy.
Yeah, I think that's a key thing. My other patient who didn't have enough tissue for upper tract disease, although she had metastatic disease, we had to start treatment. She was symptomatic. We can't get this test, so we really need those tumor uninformed tests for these patients, as well as the urine DNA.
And, when we're talking in the surveillance setting, you commented on, how the CTA test can prompt you changing the imaging cadence or kind of reflex into imaging. What happens, or how do you guide that conversation when it's the ctDNA test is positive, but the initial imaging is negative?
So I never really act on ctDNA. We have to still stick to the guidelines and, what we are treating. So unless we have data like in breast cancer, now we have that, they're switching therapies based on ctDNA. We're not there yet. So I think for us, it's still baby steps. Moving the scans earlier, detecting something, then yeah, we intervene differently. If we don't see anything, we still do scans more often than less often. But I would not switch anything based on ctDNA alone.
I think many of our patients understand what it means. We just sit down and have an honest conversation. And if we say that most of the time it's not a false positive, right? And they understand this. And they also understand that what it means to us now is just, I agree with Shilpa. It's just we need to find what's causing it, basically, is how I say it. We know it's somewhere and we know it's hiding. Let's find where it is. That's
And
sort of
like
how
my
I phrase
patient
it.
today, who has been treatment free for 2 years and we're watching this lymph node, she saw that her ctDNA shot up and she was like, yeah, I was already expecting Dr. Gupta that now you'll pull the trigger. So that was helpful, right? Patients know what to expect. And that discussion is pretty easy.
Yeah. Well, that puts us right at time. So, uh, unfortunately, I think there's one lingering about not performing cystectomy. So I think the de-escalation and what to do is a much longer conversation. So may have to leave that one. But great questions, and thank you guys for participating, and everybody for taking the time this evening to tune in.
Thanks,
Thank you.
Adam. Thanks, Laura.
Thank
Have
you
a
for,
great evening. This was
bye.
great.
Thanks for
Yeah,
having us.
yeah.